Today's class, we have seen the origin and insertion of external oblique muscle. We'll proceed with the modifications of this external oblique aponeurosis. So when you observe the lower end or lower border of external oblique aponeurosis, it is not simple. It becomes thickened and grooved, having a grooved upper surface. This thickening is called as inguinal ligament. Laterally, the inguinal ligament is attached to the anterior superior iliac spine, and medially it is attached to the pubic tubercle. So at the level of pubic crest, you can see the external oblique aponeurosis. It shows a triangular gap having a superior crest and the inferior crest. This opening is called as superficial inguinal ring, which is very prominent in males, via which the spermatic cord will descend down. That is superficial inguinal ring, superior crest, and this is the inferior crest. This is representing the attachment of the inguinal ligament. This inguinal ligament shows a upper grooved surface, and this upper grooved surface forms the floor of the inguinal canal, which is actually considered to be the weakness of the anterior abdominal wall, because the inguinal hernias are more common in males. It's actually a weakness. And this ligament, it forms the floor of the inguinal canal. So you can see floor is grooved, and it is contributed by two structures. The floor of inguinal canal is contributed by two structures: grooved upper surface of inguinal ligament and the lacunar ligament, which is the continuation of the attachment of inguinal ligament itself. So when you observe this inguinal ligament, it is not straight and slant. It is laterally curved, and the concavity is facing towards the thigh because of the attachment of fascia lata, which represents the deep fascia of the thigh. Medial part of this ligament is almost horizontal, that is attached to the pubic tubercle. Okay, so it's not a straight slant line. It is curved laterally in the lateral part of inguinal ligament, and the reason being the attachment of fascia lata of the thigh. Coming to the expansions of the ligament. So from this medial attachment of the inguinal ligament, you can see there is a triangular ligament that is extending backwards and laterally. So this is called as lacunar ligament. Since it is a triangle, it has got an apex and a base. Remember, this ligament also contributes for the formation of floor of the inguinal canal. The apex of this lacunar ligament is attached, or it is directed towards the pubic tubercle. The base of this lacunar ligament is free, and it forms the medial margin of the femoral ring. So this is called femoral ring because the femoral artery and veins are passing from the abdomen proper to that of the thigh. The next expansion is the reflected part of inguinal ligament. So from this inferior crest of the superficial inguinal ring, you can see some fibers. They pass upwards and medially and is attached to the linea alba, from where it is continuous with the similar fibers of opposite side. The pectineal ligament. This ligament is actually continuation of some fibers of lacunar ligament. So first you identify in this picture the lacunar ligament. From this lacunar ligament, you can see some fibers that is reflected over to the medial surface of the pubic bone, superior ramus of pubic bone, and that part is called as pecten pubis. The structures attached to the inguinal ligament. The upper surface, as I mentioned, it is grooved. It gives origin to two muscles, and middle 1/3 gives origin to the cremaster muscle, which is prominent in males. So altogether, 3 muscles take origin from the upper surface of the inguinal ligament. The entire lateral 2/3, it gives origin to the internal oblique muscle. You can appreciate that in this picture. Then the lateral 1/3 of it gives origin to transversus abdominis muscle. So note the difference between the origins of external, internal and transversus abdominis. External oblique muscle take origin above, gets inserted lower. Whereas internal oblique and transversus abdominis muscle, they take origin from lower part and gets inserted the upper part. So that's the difference in the muscle fibers direction as well. External oblique muscle fibers is directed downwards, forwards and medially. At right angles to each other is the muscle fibers of internal oblique muscle. Now coming to the origin of internal oblique, which I can group into 3 parts. The fibers that take origin from the inguinal ligament, and these fibers are called as inguinal fibers. Next, the fibers that take origin from the iliac crest, and the fibers that take origin from the thoracolumbar fascia. Now concentrate on the inguinal fibers here. These fibers take origin from the lateral 2/3 of the upper surface of the inguinal ligament. Some fibers take origin from the intermediate lip of the iliac crest, and some fibers take origin from the thoracolumbar fascia. Now what is this thoracolumbar fascia? I have labeled there I have colored that region green. So that is representing the thoracolumbar fascia that is covering the quadratus lumborum muscle. Okay, so that is the thoracolumbar fascia. Look at the continuity. So some fibers, they take origin from this thoracolumbar fascia. Now coming to the insertion. First we will see how the inguinal fibers of internal oblique is inserted. Look at the origin of the inguinal fibers. As the muscle fibers take origin from the lateral 2/3 of the inguinal ligament, the muscle fibers pass forwards and medially. So that is forming the anterior wall of inguinal canal. Okay, so this defect you are seeing, no, this is inguinal canal now. So floor of the inguinal canal is formed by inguinal ligament, that is external oblique muscle modification. Now the anterior wall of that inguinal canal, it is contributed by 2 muscles again. External oblique, which is removed in this picture. Reflect the external oblique, you can see this internal oblique muscle. So this internal oblique muscle fibers forms anterior wall of inguinal canal, after which it curves upwards and forms the roof. So concentrate on this region, which is colored by green. So it is forming the roof of inguinal canal. Anterior wall as well as roof of inguinal canal is contributed by the aponeurosis of internal oblique muscle. Then the inguinal fibers of this internal oblique that forms the aponeurosis that joins together with the aponeurosis of transversus abdominis muscle. Okay, so here you can make out in this picture internal oblique, first picture. The second picture you can make out the transversus abdominis muscle. So here you can see a conjoint tendon is formed. What is this conjoint tendon? It is nothing but the fusion of aponeurosis of internal oblique and transversus abdominis. Okay, and this conjoint tendon is inserted to the pubic crest and the pecten pubis. Pubic crest, I hope I have shown in the hip bone. Pubic crest and pecten pubis is the medial surface of this pubic bone, superior ramus. Next, coming to the insertion of the posterior fibers, that is the muscle fibers that take origin from the thoracolumbar fascia. So these muscle fibers, they go and get inserted to the lower border of lower 3 or 4 ribs with their costal cartilages. So that completes the internal oblique muscle. But the aponeurosis of the internal oblique muscle, the way it splits, that is the principle behind the formation of the linea semilunaris, or I can tell it is the principle of formation of the rectus sheath. Now you observe this, the internal oblique muscle, it is giving the aponeurosis. This aponeurosis, as it reaches the lateral wall of the rectus abdominis, it splits into anterior lamellae and posterior lamellae. So the point where it splits, no, that corresponds to the linea semilunaris, that you can appreciate at the lateral border of rectus abdominis muscle. And finally, this anterior and the posterior lamellae of the rectus sheath, they are inserted to the linea alba. So this splitting is there, no? That is the main concept behind the formation of the rectus sheath that covers the rectus abdominis muscle. Coming to the cremaster muscle, which is a prominent muscle in males and very poorly developed in females. So actually this muscle is a muscle fasciculi that are connected to each other by means of a thin areolar fascia called as cremaster fascia. So this cremaster muscle is a derivative of internal oblique muscle, or it is a derivative of transversus abdominis muscle, or it is derivative of both the muscles. Okay, so it passes along with the spermatic cord via the superficial inguinal ring, and it is attached to the spermatic cord as well as the scrotum here. So you can make out the attachment of the cremaster muscle to the scrotum. So this muscle is supplied by the genital branch of genitofemoral nerve, which is again a branch given by the lumbar plexus. So what is the importance of this cremaster muscle? In case of males, this cremaster muscle is very well developed because it has to provide the thermoregulation to this testis. And in case of children, there is a very prominent reflex called as cremaster reflex. That means when you scratch the medial aspect of the thigh, you can see that the testis of that particular side is pulled upwards towards the superficial inguinal ring. Okay, so this reflex is called as cremaster reflex. Okay, so when the medial aspect of the thigh is scratched, the testis should move upwards. That is because of the same nerve supply. Okay, so genitofemoral nerve is the one that supplies this region as well as to the cremaster muscle. So because of the same nerve innervation, the cremaster reflex is seen. And this is more prominent in the children than in adults. Coming to the transversus abdominis muscle, this origin I can group into 4. This is almost similar to that of internal oblique origin. So the inguinal fibers that take origin from the lateral 1/3 of the inguinal ligament, the muscle fibers that take origin from the iliac crest, thoracolumbar fascia, and ribs and the costal cartilages. Now concentrate on this picture where you can see the transversus abdominis muscle that is taking origin from the lateral 1/3 of the inguinal ligament. But these muscle fibers do not form the anterior wall. It forms the roof of the inguinal canal. So this canal you see here, so that is the inguinal canal. So transversus abdominis do not form the anterior wall of inguinal canal. It is formed only by the external oblique muscle and internal oblique muscle. Transversus abdominis muscle forms the roof of inguinal canal. Insertion. So here you can see the other origins. Insertion I'll tell later. Other origins will concentrate. So the muscle fibers that take origin from the inner lip of iliac crest, and the fibers run horizontally towards the linea alba. From the thoracolumbar fascia, these two origins are same as that of the origin of internal oblique, except that the intermediate lip comes into picture when you talk about the internal oblique muscle. Then this origin is additional to the transversus abdominis muscle. It takes origin from the lower 6 ribs. Coming to the insertion, look at the way it is forming the roof of the inguinal canal. So here in this picture, blue colored one is representing the inguinal canal. So transversus abdominis muscle, it forms the roof of the inguinal canal, and roof is also contributed by the aponeurosis of internal oblique. Then it joins with the aponeurosis of the internal oblique to form a structure called as conjoint tendon that is inserted to pubic crest as well as pecten pubis. Transversus abdominis muscle, the remaining fibers, it forms the aponeurosis, and this aponeurosis forms the posterior wall of the rectus sheath, 3/4, and 1/4, the lower part, it forms the anterior wall of rectus sheath. Okay, so rectus sheath is contributed by all the 3 muscle aponeurosis. External oblique forms only the anterior wall. Internal oblique forms both anterior as well as posterior wall of rectus sheath. Transversus abdominis, most of it, that is upper 3/4, will form the posterior wall, and only a small part of this transversus abdominis aponeurosis forms the anterior wall of rectus sheath. Coming to what is conjoint tendon. As I mentioned before, conjoint means it is formed because of the union of the aponeurosis of internal oblique muscle and the transversus abdominis muscle. Attachment of this conjoint tendon is, look at the picture here, it is attached medially to the pubic crest. Trace it laterally, it goes and gets attached to the pecten pubis. Conjoint tendon is formed or contributed, 3/4 of the contribution is by transversus abdominis and 1/3 is only by the internal oblique muscle. Now coming to the fascia transversalis or transversalis fascia that covers the inner surface of the muscle, transversus abdominis muscle. This fascia is actually an areolar membrane, and it is continuous with the fascia of opposite side behind the linea alba. Okay, behind the posterior wall of rectus sheath, it is continuous with that of the opposite areolar membrane. That is same layer, fascia transversalis. Now, this fascia transversalis has a special feature. That is, it has got a defect, and the defect name is deep inguinal ring. Like how you saw, there was a superficial inguinal ring. That was a proper triangular gap that you appreciated in the external oblique aponeurosis. This is the deep inguinal ring, which you can actually tell that it is a defect of this membrane. And this is situated 1.25 centimeter above the mid-inguinal point. Mid-inguinal point, I have mentioned, it is extending from anterior superior iliac spine to that of the symphysis pubis. So this is mid-inguinal point. Midpoint of inguinal ligament is different. Midpoint of inguinal ligament is between the anterior superior iliac spine and pubic tubercle. Okay, so midpoint of inguinal ligament. For that, you should know the attachment of inguinal ligament. What is the attachment of inguinal ligament? Laterally, anterior superior iliac spine. Medially, it is attached to pubic tubercle. Their points will differ. So, mid-inguinal point and midpoint of inguinal ligament are 2 different points. Coming to the nerve supply of these muscles. So, external oblique is supplied by the ventral rami of lower 6 thoracic nerves by both its lateral branches as well as anterior branch. Internal oblique and transversus abdominis muscle, it is supplied by the ventral rami of lower 6 thoracic nerve, and in addition, it is supplied by first lumbar nerve. So, this is the nerve supply of the 3 muscles. The functions of it, to give a reading. Coming to the abdominal incisions, I'm not going to cover in much detail about this because you're going to study it in the surgical postings. Let's begin with the case presentation where a 60-year-old diabetic male patient had a large pyamic abscess on the abdominal wall below and to the right of the umbilicus. So, Pyamic abscess means the abscess is filled with the pus. An incision and drainage of the abscess was done, and within 2 hours of the surgery, the surgeon was called to see the patient who had hypertension and blood was pouring out of the incision profusely. So when the surgeon came and explored the wound, it revealed that large clots and profuse bleeding from the inferior epigastric artery, which was ligated by mistake. So that was the reason why there was a hypertension. Hypertension was because of the excessive loss of blood. As I mentioned, the blood supply of the anterior abdominal wall, superior epigastric artery, inferior epigastric artery. So inferior epigastric artery is seen within the rectus sheath. So when draining the abscess, when the inferior epigastric artery was tore by mistake, you could see this patient was bleeding profusely. So unless and until there is an emergency condition, abdominal surgeries are avoided. So anatomical weak areas of the abdomen are rings, that is superficial inguinal ring, deep inguinal ring, or the junctions, the empty spaces, as I mentioned, inguinal canal. Apart from that, there are other spaces like superficial inguinal space, all that. So they are all from the weak areas of the abdomen. And these weaknesses of the abdomen will lead into the conditions called as hernia. Hernia means abnormal protrusion of abdominal contents outside. Okay, so that's called as herniation. Other conditions where the abdomen needs the investigation is pyogenic abscess, as I mentioned in the case the previous slide, and abdominal wall veins dilation. Recollect the caput medusae which I had shown because of portal hypertension. Coming to the basics of the abdominal excision. See, abdomen is touched only when the surgeries are planned or during the emergency condition. C-section will come in one of the planned surgeries or sometimes the emergency surgeries in case of females. Coming to the vertical incisions, midline incision is always the safest and the best incision ever. That's because there is a minimal loss of blood, and midline incision above the umbilicus is mostly preferred because linea alba is comparatively wider above the umbilicus. Paramedial incision, that is on either side of linea alba, leaving about 1 to 2 centimeters away from the linea alba. Transverse incisions are of 4 types, the names of which I don't want to mention because it's a little complicated. Oblique incision, that is subcostal incision and McBurney's incision. And so in this picture, see, medial incision that extends from the xiphoid process to that of the symphysis pubis. And always remember, umbilicus is not to be incised. Why? Because you remember there was something called as fibrous skeleton of the heart. Okay, that is the foundation stone. Likewise, umbilicus is considered to be the foundation stone. It's a very important fibrous tissue. So never incise the umbilicus. So it has to be preserved in any kind of surgeries. So this is the linea alba. So midline incision is always favored. So you can see how the umbilicus is spared in the midline incision. Now next, coming to the paramedial incision and pararectus incision. So paramedial incision may be 1 to 2 centimeters away from this linea alba. It is considered to be slightly safest because you cannot see any nerves like much coming and piercing them. But pararectus incision, as much as possible, we have to avoid. That is because first thing is it corresponds with that of the linea semilunaris, where the anterior cutaneous nerve may pierce the rectus sheath and it enters within the rectus sheath. So that's why the pararectus incision is not so much preferably advisable. So paramedian, and the most preferable one is the medial incision. Coming to the subcostal incision, so that kind of incision, you have to feel for the costal margins, and mostly for the operation for the emergency operations of gallbladder and spleen, mostly we follow the subcostal incision. and McBurney's incision, that is for the excision of the inflamed appendix. So what is this McBurney's point? McBurney's point is a point that lies medial 2/3 and lateral 1/3 of anterior superior iliac spine. So approximately in this junction. So take a point of medial 2/3 from the umbilicus downwards and laterally, and from anterior superior iliac spine 1/3. So this particular junction is called as McBurney's point, and there the incision is made to incise the appendix, inflamed appendix. A word about the development of anterior abdominal wall. This anterior abdominal wall, there is surface ectoderm, the mesoderm, and the endoderm. So surface ectoderm, or you can say the skin, is derived from the ectoderm, that's the basic germ layer. But the muscles of the anterior abdominal wall is derived from the paraxial mesoderm. This is the neural tube in this picture, and on either side of the neural tube you can see there is paraxial mesoderm, there is intermediate mesoderm and lateral plate mesoderm. Let's concentrate only on the paraxial mesoderm. So this paraxial mesoderm, it undergoes a series of segmentation and gives rise to the formation of somites, and these somites will further divide into sclerotome and dermomyotome. This myotome migrate to their respective locations, that the muscles of upper limb will migrate to upper limb. So the muscles of the thorax, abdomen will migrate to their respective regions. So ultimately, the muscles of the body, it's derived mainly from the it's mainly derived from the myotome. The connective tissue of the body wall, that is anterior abdominal wall, it's derived from the somatic mesoderm. Then the infraumbilical part of the anterior abdominal wall, that is developed from the cells that migrate from the lower end of the primitive string. So that completes the anterior abdominal wall. Thank you.